Okay. So we will start viewing the slides, and okay. So disclosure, we have nothing to disclose, but the parents have granted permission for this presentation because we are going to show you some pictures of the parents. So in my introduction, the anticipated delivery at the threshold of viability presents with difficult ethical issues for caregivers and the families. Despite previously published guidelines, there is still no consensus on this subject universally. This is one of the most controversial and emotionally charged area in perinatology, both for parents, nurses, physicians, and resident doctors and, and students. So we're still on my introduction of antenatal steroids. When the baby is still in utero, surfactant therapy, parenteral nutrition, and mechanical ventilation in different modes, and also the use of mother's milk has made a major contribution for premature tiny babies to survive. Difficult questions always arise when the infants are born extremely premature. Who gets to decide if an extremely premature baby will be resuscitated and what criteria should be used? And these are now being developed by different nations, different countries, and we will try to just talk something about that. Yeah. Okay. Antenatal treatment decisions at this stage are very complex. Both mother and the fetus are affected. Balance between risk and benefit may be quite different for each of them. After thorough discussion of all currently available information, these difficult decisions should be made in collaboration with parents, their obstetrician, and their neonatologist or pediatrician, and also a group of people who help these doctors, such as nurses, nurse practitioners, residents, and fellows who work in these institutions. It takes a village to take care of these babies, so we should all work together, respect each other's feelings, and support it. Okay, just a second. So I will usually, I make these as case-based learning. So this, I'll present to the maternal history. She's 17 years old. She's gravida 1 and now para 1. And there is young father also involved. Mom is O positive and antenatal screens were all negative. That means, rule out syphilis and congenital gonococcal infection. These are basic screens which they do it here. And I'm sure they are being done other places too. And then medications during pregnancy, she received magnesium sulfate and betamethasone as part of the treatment. Magnesium sulfate has been used, and there's a controversial issues about that, but there is some help. It is also used as a neuroprotective agent and also to arrest labor to buy more time. This mother received prenatal care by Texas Tech OB. This is our OB department. There is no history of alcohol, cigarette smoking, or substance abuse. And she had a history of Evans syndrome or HELP syndrome, which is hemolysis and low platelets and thrombocytopenia. Okay. Baby was delivered at 23 weeks gestation. And this was still considered the age of viability, threshold of viability. Now, actually, in the Western countries, especially in the United States, this number has gone down to 22 weeks now. And, not all babies will make it, but still they are trying to help these babies and see what the response is. This baby was delivered by C-section due to pregnancy-induced hypertension, thrombocytopenia, and the syndrome, which I talked before. APGAR score at 1 minute was 4, and which usually is the case in these premature babies. The first APGAR is low, but at 5 minutes with good resuscitation, the APGAR improved to 7 at 5 minutes, which is a pretty decent score. And therefore, in these situations, our students' exams are in their exam, they get this question: what do you mean if the baby has a 1 minute APGAR low? Is it going to cause damage to the baby? But the answer is no, it just means that we should continue resuscitation till the APGAR score reaches 7. So this baby at that time was intubated in the delivery room and was given surfactant. This modality has changed a little bit. Nowadays, we are not intubating all babies. The first line of treatment is use of nasal CPAP. And if the baby is responding, if the baby is not responding, then these babies are intubated. Even if they are given surfactant, then usually they are extubated and placed on nasal CPAP to prevent damage to the lungs and in a way to decrease the incidence of chronic lung disease. Let's talk about the baby a little bit. The Ballard scoring system. The baby, by that test, baby was 23 weeks. And this is not a very objective test. It could be variable. Nowadays, they gave this diagnosis by ultrasound, which is quite accurate, and there is a error of 1 week plus minus. Baby's weight, as you know, was 4.6 grams or kilograms, and it was less than 500 grams. Length was 25 centimeters. Head circumference was 20 centimeters. And these are lower values of these babies. Head circumference was also the vital signs. The baby's temperature was 98 degrees. Heart rate was 135. Rests were 35 per minute. Blood pressure was 35/23 with a mean of 27. So you think the temperature was normal or abnormal? And in centigrade, normal, right? We try to keep the temperature for 36.5 to 37.5 degrees Celsius. Heart rate, what do you think about the heart rate?
Sir, normal.
Normal, very normal, good. And respirations?
Sir, normal.
Normal. Blood pressure?
Sir, blood pressure, we have to see according to the scale or graph.
Very good answer. There are graphs now available, and they connect with the gestation age, and that's what we should use. For the term baby, I think I mentioned here before, what is the term baby's blood pressure should be? Full term baby's blood pressure. Maybe I talk to another different, it's 70/35. 70/35 millimeters of mercury. Just kind of remember that this is for a term baby, but for premature babies, it's based on weight. Okay, good. And the head examination, the anterior fontanelle open and soft, but they were bruising on the head because little babies, as you know, get bruised very easy because of thin skin. Chest and lungs, equal breath sounds, cardiovascular system, the regular rate and rhythm, and there was no murmur noticed. Abdomen was soft and lax, and there was no organomegaly. Extremities were within normal limit, and neurological examination was appropriate for gestation age. So there was premature babies, lower neurological assessment. The thing which we go by is, in neurologically, what do you think? The muscle tone of the baby. If the baby is flaccid, that means that the baby is neurologically immature, and that is flexion. Flexion, it correlates with the gestational age assessment. More flex the baby is, more mature the baby is. So you can use that as a little saying. This baby, if you plotted on the growth curve, he was appropriate for gestation age. He was not small, neither large, but appropriate for gestation. Okay, good. So this was the management in the NICU. We work as a team. So first thing we look at is the healthcare maintenance. So in that, usually in those days, we were not feeding babies, so that baby was kept NPO due to gut decreased motility, but it is changing, and we'll go over that. The baby was started on IV fluid. Baby was also started on TPN. Baby had marked metabolic imbalance. He had metabolic acidosis since day of life 3. Lactic acid was 9 milligrams. The normal is around 3 or less than 3. The baby's pH was 7.1. Baby did have hyperglycemia, hypernatremia, hypochloremia, hypocalcemia, and hyperphosphatemia. So what are the reasons for these abnormalities? Hyperglycemia, why they become hyperglycemic? Anybody?
Sir, less weight, due to less weight, NPO, and then less reserve.
Yeah, that's good. But main reason is there is paucity of insulin. Insulin is not really produced well to control this hyperglycemia. Then hypernatremia, why these babies become hypernatremic?
Doctor, due to less volume.
And what else? They become hypernatremic because their skin is very thin and they lose the fluid and the sodium level will go up. Similarly, hyperchloremia.
And sir, can insulin also contribute in hypernatremia? Lack of insulin?
Yes, you know which way? When they are hyperglycemic, they urinate more. So they lose more fluid, and plus the skin is very thin. So that, yes, you're right. Hypocalcemia is quite common in premature babies because parathyroid hormone is not activated as yet. It goes to sleep and it takes a while. So that's why once the umbilical cord is cut off, they do become hypocalcemic and they have hyperphosphatemia. This is due to the breakdown of the muscles and less urine output at that time. Okay. So central nervous system, as I mentioned before, premature babies are hypotonic, and also routinely screen them out for bleeding in the interventricular hemorrhage, and it showed grade 3 to grade 4 interventricular hemorrhage. It's quite common finding, which is decreasing now. You know why it is decreasing? What protects them?
Sir, due to management, good management?
Management is one, good resuscitation, and what else?
Delay cord clamping?
That could be a possibility, protective. One more.
Caffeine?
And caffeine comes later, but getting antenatal steroids given to the mother regulates their thing, blood-brain barrier. So that is really the main reason. Interventricular hemorrhage incidence used to be about 20 to 30%. Now with this, it has decreased much less than that. Gentle management, keeping good resuscitation, keeping these babies warm, all of these has played, and main thing is antenatal steroids. Okay. In the respiratory system, the baby had respiratory distress due to perceived surfactant deficiency. He also developed PIE. You know what PI means? It is a lung injury caused by intubation and ventilation. It's called as a pulmonary interstitial emphysema. And this is also not a very good thing. So that's why we are not intubating many babies right away. We are giving them time, give them CPAP and non-invasive ventilation. Baby initially was on conventional ventilator at that time. After PIA developed, he received high frequency ventilation. That was the treatment for these babies initially. Okay. In the cardiovascular system, this baby had hypertension and required dopamine and dobutamine at that time. Now people are shying away from dopamine and dobutamine, but sometimes we have to use it to maintain good circulation, good blood pressure. Okay. Why these babies are hypertensive? Do you know why? Huh? Where is Talat Mahmood? Do you know? The cardiac muscle mass is very weak. The pump is weak, so they do not pump strongly. This is one of the reasons for hypertension, and the other reasons also come into. Okay, good. GI system, the baby was kept NPO and he did not have any issues. Later on the GI system, he was kept NPO. Nowadays, we start feeding, as you have listened to the previous speakers, trophic feedings soon after birth. And so initially, long time ago, we did not feed these babies for good 2 weeks, and then there were complications. So now, as long as the baby becomes stable, we start small amount of feedings. And what is the best feeding element? What should we use?
Sir, EBM, sure.
Huh?
Sir, EBM.
Mother's milk or EBM, yes, you are right. Mother's own milk, if you don't have that, then donor milk could be used, and that has really helped a lot. One of the things it did decrease the incidence of necrotizing enterocolitis. Okay, good. The baby developed AKI, acute kidney injury. This was due to the low blood pressures. Baby developed oliguria and renal failure. The last BUN was 61 and the creatinine was 2.8. The high BUN doesn't really be very much. Excuse me. Be very much because this is due to the brain breakdown of the muscle mass, and the creatinine can go up, and it's well accepted. BUN, creatinine is the one they looked at, and the urine output. What should be the normal urine output for these babies? cc's per kilogram per hour? Do you all know? Initially, they are oliguric, and they may have half a cc per kilogram per hour of urine output or none, and that is all anuria. And then they start increasing and the kidney starts stabilizing, and then they start putting out at least 2 to 4 cc's per kilogram per hour. So that is a good urine output. Okay, so this is how do they measure this in your hospital? You know?
Sir, we weigh the diapers.
Very good. You always know all the answers, even previous talks. So that's good. That's what we do.
Thank you, sir.
Okay. I'm happy to know that you know a lot of things. Okay. hematological system, and this baby had anemia prematurity. The lowest hemoglobin was 7.8 grams on day of life 3, and the baby had received transfusion. Now anemia, we are seeing less due to delay cord clamping, but anemia can happen. There are two reasons for that. We draw a lot of blood out of these babies, and this is called as the phlebotomy losses. So, but delayed cord clamping is helping. Do you all do delayed cord clamping? What is your time?
Sir, we wait for 1 minute.
Yeah, very good. Yeah, 1 minute. And initially they used to 30 seconds, but 30 seconds to 1 minute is the delayed cord clamping. Or they used to give cord stripping. You strip the cord, but now there's a controversy. It may not be indicated in very premature babies. Bilirubin was 8.3, which is common. Baby received phototherapy. The last bilirubin was 5.8. Baby also had thrombocytopenia. The lowest platelet count was 48,000. And this is a quite common problem in premature babies who are admitted to the NICU. Okay. Infectious diseases, the baby was suspected to have sepsis. He was started on ampicillin and gentamicin. However, the blood cultures came back negative and the antibiotics were stopped. Due to extreme prematurity and instability, the baby was at risk for infection. So antibiotics, nowadays, if the cultures are negative, baby is stable, we should stop the antibiotics. And this is the antibiotic stewardship, which I think you all are doing too. Longer we put them on antibiotics, there are more complications. Resistance develop, increase the risk of NAC. Okay. Family and social, which is very important part of our patient care. Both of the parents were actively involved with this baby's care. Prenatal consult was provided. Parents were aware of the condition. Due to the critical condition of this baby, physicians and parents conferences were held. And I think you call in Karachi, they call them as parent counseling. And when I had gone there, we all do parent counseling frequently. The parents agreed with the palliative care and they signed the DNR on day of life 6 because the baby started failing. Palliative care was provided and the baby passed away while being held by his mother and father. And this is one of our residents taking care of another. This is not this same baby, but another baby in our center where she is trying to put the central venous catheter, umbilical vein and umbilical artery, and the baby is intubated, baby is on the radiant warmer. Now things have changed also. Now babies are placed in incubators, and these are called as the giraffe beds, which have very high humidity, 70%, and it is beneficial for the babies. So objectives are outcome of babies at borderline variability. What is the global thoughts about that? What are the ethical consideration, differences of opinion, counseling of parents, assessment and care at the delivery room, limits of continuing care in the NICU, the futility of continuing treatments, care after withdrawing ventilatory support, and future directions. So what is viability? Viability means the quality or state of being able to live, grow, and develop. The limit of viability has changed with advancement of perinatal and neonatal care. Not long ago, the limit of viability, even in developed nations, was about 28 weeks gestation. Now it has gone, as I mentioned before, down to 22 weeks gestation. Currently, in developed countries, the limit of viability ranges from 22 to 25 weeks. And in developing nations, the limit of viability is 28 weeks. But now I think you have told me that your viability limit is down to about 24 weeks. Do you agree with that? Huh?
Yes, sir, I agree.
Yeah, and I think the best for the river is 25 weeks is a good time if you don't have all the equipment and so on. And then also look at the response to the baby in the delivery room assessment. Okay, good. So what us WHO or guidelines for live birth? You know what is a live birth means? A live birth refers to the complete expulsion or extension from the mother of a product of conception, irrespective of the duration of pregnancy, which after such separation, after such separation, when the cord is breathes or shows signs of beating heart, pulsation of the umbilical cord. So this is kind of a live birth. Movements of the voluntary muscles, whether or not the umbilical cord has been cut or the placenta has been separated. So this is like a definition of a WHO definition of live birth. Each product of such a birth is considered a live newborn, no matter what the gestation age is. Okay. Limited to the, yeah, okay. With continued progress in perinatal care, the use of antenatal steroids, delivering these babies and level 3 hospitals, and well-versed with neonatal resuscitation program, maintaining the temperature and so on. Morbidity and mortality is still high for these infants between 10 to 22 to 25 weeks gestation. Only about 30 to 40% of these babies may survive, and about half of them will have long-term implications at different level. The threshold of human viability is limited by the physiological development, number one, of the lungs, occurring at 22 to 24 weeks of gestation. So that is, the babies are now, can make it at around 22 weeks gestation because the care of the lung and so on. The intact survival is not expected to improve with current technological resources. So what is a borderline viability? Gestational age of 22 to 25 weeks gestation. And that's what, below 22 weeks, usually intervention is not done. The burden of intensive care, balance between legacy of impairments and benefit of survival. So we have to look at that. I have seen, even if the baby has survived and issues, parents never are even very happy to take care of such a baby. Okay, so global perspective. In Australia, this is a report from 2006, baby at 22 weeks gestation. At that time, they did not resuscitate them, and they only provide comfort care. At 23 weeks, comfort care, and they start providing active care at 24 weeks. So it's changing a little bit. And at 25 weeks, it was always these babies should be resuscitated, not 24 weeks. And 23 weeks depends upon the family and knowledge. In Canada, from 2012, at 22 weeks, they provide comfort care, and 23 weeks comfort care, and 24 weeks parental wishes, and 25 weeks full care. In Germany, 2008, individualized care, and at 23 weeks comfort care, and at 24 weeks the parents' wishes, and active care provided at 25 weeks is a landmark we have known for a long time. ILCOR, international decisions for different countries. It's published in the NRP guidelines, that is 2006. At 22 weeks, in those days, are providing only comfort care. Now this has changed in many centers, and at 23 weeks, it depends upon individual care. In individual care, In New Zealand, 2011, they have no recommendations for babies at low gestation age, 22 weeks, at 23 weeks, no resuscitation, and at 24 weeks. So I think their things have also changed now. In the United States, in 2014, comfort care was supposed to be given to babies at 20, but now recently this year, at 22 weeks, we should offer resuscitation. At 23 weeks, individual decision based on parents and the physicians and nurses who are part of the team. And then at 24 weeks, active care, and definitely all care. Okay, Canada, Australia, Canada, Germany, UK, United States. So this is the percentage survival by country. Australia, at 22 weeks, they had, in their previous report, they had no survivals. At 23 weeks, they had 29% survival, and at 24 weeks, 50%, and 25 weeks, 65% survival. Canada, 22 weeks, 0, at 23 weeks, 14%, at 24 weeks, 58%, and that at 25 weeks. 25 weeks is really landmark change. 65% of the baby, they survived. Germany, they had no data for 22 weeks, and for 23 weeks, 50% of their babies would survive with intervention, and at 24 weeks, 60%, and at 25 weeks, 75%. Around 25 weeks, there is really maturity of the organs, lungs, and so on. At United Kingdom, at 22 weeks, only 1% survived. At 23 weeks, 11%, 24 weeks, 26%, and at 25 weeks, 44%. In the United States, at 22 weeks now, 21%, at 23 weeks, 30%, and at 24 weeks, 50%, and at 25 weeks gestation, 75% of the babies have been reported to, with all the good OB care, delivery room care, and so on. Okay, so American Academy of Pediatrics, there are guidelines. I don't know if you have guidelines from Pakistan Pediatric Association. I think they're working on that, but I'm not sure. Palliative care should be offered at 22 weeks. Now it has come down to 22 weeks, and at 23 weeks, individualize the cases. At 24 weeks, individualize the cases, and at 25 weeks, individualize the cases. In individual cases may be considered maybe considered at 24 weeks, and at 23 weeks, it could be considered, but now it has gone down. This year tells us that 22 weeks is the one we should intervene. Okay. Summary of recommendation for resuscitation at birth. This is a 2008 study. This is United Kingdom guidelines. At 21 weeks, for them, no resuscitation. They think it is an experimental procedure, and exceptions are only as part of research protocol with consent by parents and the team. At 22 weeks in United Kingdom, they were not giving any resuscitation or at parents' respect after prolonged and fully informed discussion of the risks, implications, and the likely outcome. 23 weeks could be defined, and proceeding should be given to parents' wishes. If left to clinicians, then the clinical team should decide what constitutes appropriate care for that particular baby. 24 weeks, we should resuscitate them, and also at 25 weeks, resuscitation is offered unless severe abnormality incompatible with any significant birth defects. This is the ILCOR, International Liaison of um, um, which had grouped together at 22 weeks, palliative care. But now United States has gone down to offer in certain cases 23 weeks, not specifically known, 24 weeks, no, individual cases, 25 weeks with fetal anomalies or severe distress, it is withheld. And 20 fetal anomalies or distress. And CPR is not indicated at 22 weeks gestation, 23 weeks on parental request and the team's guidelines, 24 weeks on parental respect. 25 weeks, as we mentioned before, always indicated, and now it has gone down. And also 26 weeks, always indicated. Ethical issues and dilemmas. Care of very preterm infant implies a variety of complex medical, social, and economical aspects that calls for ethical decisions to be made. Boundaries between utility and fatality are unclear. Infants' best interest, wishes of parents, and the actions of physicians led to the ethical issues and dilemmas in the perinatal and neonatal arena. The majority of these infants will die before, during, or after birth in the NICU. Many survivors will die before their first birthday. Approximately 50% will suffer from moderate to severe neurodevelopmental outcome, but the outcome is getting better at 6 years of age. Some of them will develop some kind of learning disabilities. They may not be good in math. They all may have to wear glasses, but they may not have major issues. And the parents really do not mind. They want their baby to be there with them. Directors for healthcare teams and to the parents to help parents and physicians. Various forms of guidelines have been approved by many universal scientific societies. According to the Institute of Medicine, clinical practice guidelines should be systematically developed in each institution where the babies are born. Statement to assess practitioners and patients regarding decisions about appropriate healthcare for specific clinical should be formulated, to resuscitate, not to resuscitate, what temperature to keep. So you should have those protocols. Recommendation should be explicit with definite intent to influence what physicians, clinicians do. So, temperature control is an important issue. Control of oxygen therapy is an issue. Gentle ventilation is an issue. TPN availability and early feeding is an issue. So neonatal survival and morbidity by gestation age, this is from the United States National Institute of Childhood and Development. There are, I think, about 34 or 35 centers, level 3 centers, which are teaching hospitals, and this is their guideline and follow-up. At 23 weeks gestation, mean survival for these babies was 30%. Disability was half of these babies had disability, mild, moderate to severe. At 24 weeks, 52% survival and 53% had disabilities, which could be variable. At 25 weeks, 76%. This is a landmark gestation age, and 46% would have some kind of disability. Weight in grams, with a 401 to 500 grams, mean survival was 11%. Disability has not been calculated, and 501 to 600 survival rate is 27%, and disability was 29%. 601 to 700 grams, these were the 100-gram availability, 63% survived, and 30% had some disability. 701 to 800, 74% will survive, and 28%. So we used to also do that when I was their fellow. We had to do all these measurements and look at the outcome. Condition, serious neonatal, this is also National Childhood Studies. Did I talk about that? Yeah, I think I did. Yeah, conditions, chronic conditions of these babies, morbidities, respiratory distress syndrome is seen in 78% because the lungs are not producing surfactant, they have all respiratory distress. And do you know what are the 4 signs of respiratory distress? Huh? Clinical signs. Anybody? Fellows, residents, nursing staff. What are the 4 signs of respiratory distress? Huh?
Sir, nasal flaring, grunting, tachypnea.
And cyanosis. Yeah.
Okay.
So number 1, tachypnea, by definition, breathing rate more than 60, retractions, and number 3, grunting, right? And number 4 is cyanosis. Good. NEC was seen in 14% of the cases. Sepsis was seen in the quite high, 48%, because of the lack of immunity. Grade 3 IVH was 13% and grade 4 was 13%. Periventricular leukomalacia was seen in 7%. Growth failures were seen in 100% of these babies. They did not grow very well because nutrition was effective. And then in many babies it did. And this outcome, growth failure, is better now with the early use of TPN, early use of mother's milk, and adjustment of calories. UK information from 2000, complicated. So in live births, they had 138 live births at 23 weeks, 241, 382, and at 25 weeks, 421. The survival per live birth percent, it was 1% at 22 weeks, 11% at 23 weeks, 26% at 24 weeks, and 44% at 25 weeks gestation. Assessment at 6 years of age, their development, at 100% of these babies had issues. At 23 weeks, it dropped down to 88%, and 24 weeks, 74%. I think this is the frequency of follow-up and survival. In this one, this is at 6 years of age, and there were severe disabilities in 22 weeks gestation. 50% of these babies, as gestational age advanced, these disabilities decreased, and moderate disability was 41% and dropped down to 22%, and then 22%. Moderate disability, 0, 41, 22, 22. Mild, no disability was seen mild to no disability was seen in 50% of the cases. At 23 weeks, 36%. At 24 weeks, 49%, almost 50%. And at 25 weeks, mild or no disability was seen in about 60% of the babies. Severe disability means, this is Epicure study from England, highly dependent on caregivers, e.g. unable to walk, very low IQ, profound hearing loss, and visual loss. So this is a severe disability. Moderate disability is reasonable level of independence, e.g., for example, able to walk, below average IQ, correctable hearing loss, and impaired vision. So that's why it's very important to follow these things. In mild disability, learning disability, squinting, or no disability. And most of these babies will have need for glasses and so on. Okay. This one, we did a little study in our hospital where I worked, and some of the residents helped me. this was a long time ago, completed weeks of gestation less than 23 weeks, and babies who were born alive were only 4 babies in this group. 24 to 25 weeks, 19% of these babies, and at 25 to 9% expired. 4 babies at 23 weeks, equal death rate, and at 24 to 25 weeks, 9 babies died. And then at 26 to 20, only 1 baby died. Percentage mortality was 100% at 23 weeks, 24 weeks, about half of that, and then 26 to 27 weeks, only mortality is 11 babies. And this is how we have seen each day makes a difference in the outcome of long-term and immediate. Also, we looked at the gender distribution. We had 9 out of these 22 total babies, 9 were female. Mortality was 40%, and male was 5 out of 10, and mortality was 50%. As you know, mortality and death rate is higher in male babies and lesser in female babies. They think it's due to extra X chromosome, XX. The boys have only 1 X, right? That's what they say. Females are a stronger breed, right? Do you all agree? Huh? No? And their follow-up information is not available. Management of periviable infants. There is gaps in knowledge. Obstetrical issues, evidence-based management approach for medical and OB complications, identification of sensitive markers for in utero therapy, etiology of periviable births, and develop tools to treat intrauterine infections, periviable birth survival in relation to gender and race. So as I mentioned before, more male babies would die in this group, and more babies who belong to the African American race, there are more death rate. Accurate gaps in knowledge. There's accurate assessment of gestation age and field well-being should be done. Sometimes, anecdotal data is used, and they may do intervention at wrong times. Specific prenatal therapy, control of high blood pressure, diabetes, impact of medical counseling and OB to neonatal care, and identification of there should be combined meetings with OB and neonatal group to come on to the conclusion. And identification of prenatal markers. And this is what they are now looking. This is the era of DNA and RNA markers of infection, and people are working on that. So, and then how preterm labor starts and how we can intervene, still in the process. Okay. So the other gap is acute delivery room therapy. What should we do? Pulmonary and cardiovascular support, fluid, electrolyte, nutrition, and environmental care, postnatal growth rates, skin care, barrier functions and risk of infection, infection prevention, brain injury and healing, the improvement of long-term outcome in relation to the chronic medical illnesses. The 4 ethical principles we should know. Number 1 is autonomy. Respect individual rights of freedom and liberty to make choices that affect his or her life. And similarly, it is the autonomy at that time given to parents to make the decision. Beneficence, act as to benefit others. So give benefit to others. Sometimes it may not be beneficial to keep on keeping these tiny babies alive, let them suffer from pain, and non-maleficence, avoid harming others, unjustifiable and justice. Treat people truthfully and fairly as you want to be treated. So these are the 4 major ethical principles. I think, do you all use the same? No? So these should be put in the nurseries, typed, and so that you can go by them. And that's what is important. I don't know. So you have a little different cultural issues and language issues and educational background. So that's why it is very important to focus the education of the mother so that you can help them out. Do you agree with that? No? Okay. Degree of pain and suffering should be included. Whether medical intervention is futile in certain circumstances.
Yes, sir. Agree, sir.
Can you hear? What did you say? No? The likelihood of survival free of serious disability, the impact on the family, should there be a legacy of serious disability. Based on perception of others' best interests, others, parents, and our medical staff. These are the best interests. We should all participate in that. The variable outcome of these infants colors the perception of parents and the healthcare team. We may be guided by data on average survival and risk of disability among survivors. No reliable markers or outcome for individual infants are available at the time of decision making or shortly before or afterwards. So this is a major issue. To provide parents information regarding chance of survival, we should do counseling to inform parents regarding immediate neonatal problems. Parents should also be informed regarding chronic medical problems such as BPD, retinopathy prematurity, NEC, and IVH. When I worked in Amarillo, we had a consent paper and we went over that. I hope I may be able to show you that. And it was all given. Parents are talked about that. Then in the presence of the obstetrician and a neonatal team, 1 nurse from each side to inform the parents. Combined counseling with OB, neonatologists, and the nursing staff is very, very important. Do you participate, nurses, do you participate in decision making? Huh?
Yes, sir. We do give our input to share with doctor what the intervention baby will be able to tolerate, or where we need to go for, where we should hold on. Like for example, doctor suggests that can we wean off oxygen or we drop down. If we think baby will not be able to, we do suggest and give our input.
They're very, very important as a teamwork. And you know, I remember the times of the past in the 80s. There was no consensus between doctors and nurses. And in the delivery room, there used to be always a fight between the nursing team and the doctor's team. And each team was pulling the baby to themselves. I'm glad that doesn't happen anymore, but it used to be quite common. So at the delivery room, careful assessment at birth by an experienced neonatologist or a nurse practitioner and a senior resident or fellows should be there. And the nursing staff has a strong input in that because they work with these families, confirm signs of life. That means, you know, heart rate, breathing, and so on. Assessment of gestational age and formation of opinion, whether OB gestation age matches with the physical assessment. So usually the OB gestation age is used now with use of early ultrasound. The days of the uterine size and so on have gone. Either we have to do an early ultrasound, fetal ultrasound, around the 9th and the 10th week, and they gave us good results of that. They tell us this baby is 22 weeks gestation and 4 days, so fairly accurate. Previously, you know, we used to go by uterine size and when the baby moved. So those are, you know, subjective. To assess the physical condition, including vital signs and presence of lethal malformations and anomalies, to decide whether any medical intervention is appropriate, and according to the discussions with parents during antenatal counseling. The infant in the delivery room is viable, should be stabilized using the NRP guideline. And I told you what viability means. If there is a positive response, the infant should be transferred to the NICU for further care. NICU management should be evidence-based. Frequent communication should be held between parents and the medical staff. And remember, when I had gone to Pakistan, I give some time in Aga Khan institution, and I remember I saw the doctors and fellows, they had a counseling parents and they used to meet with them. Limits of continuing care in the NICU: if the baby has a greater risk of developing wide range of neonatal complications, temptation for younger clinical staff is to see each complication as a challenge to be met at all costs, simply because the baby is a patient in their NICU. In contrast, NICU should be seen as providing a supportive role to parents while the baby is undergoing a trial of life. Okay, aggressive treatment at times becomes futile when there is a multiple organ failure, no signs of improvement, conditions steadily deteriorating, and the baby may have massive intracranial hemorrhage. This part has also changed a little bit. Incidence of severe hemorrhage is decreasing because of antenatal steroids. And even if it is there, now I've seen some babies do okay with good management. So it is not no. So this is a chart made by one of our student who was working with me. So it kind of lists everything, person who talks to them, and then whosoever was present, and on which date, what are the vital sign, weight and stuff, what was the status of the lungs, jaundice, and then infections, bowel things, cardiovascular, brain and eyes, kidneys and bones, and any lab data. So one person used to go, and this was before birth, we used to go over each things, and we discovered and give it to them. And here in the brain, hemorrhages, ROP was discussed. And then we signed it and dated, and then we used to give one of these original data to the OB doctor or to the OB team, OB nurses. They would put it in the mother's chart. Preparation of palliative care. Once we think that the baby is not going to make it, inform the parents what process normally entails. Give them the opportunity to contribute to their baby's care, such as bathing, taking care of. Help them understand that following extubation, a variable length of time will elapse before their baby will die. So if the baby has to extubate, you have to tell them and ask them if they want to be there. Some parents do not want to be there, some would. So you go by their wishes. So after withdrawing the ventilatory support, an optimal environment should be provided. Surroundings should be compassionate. Staff should be non-judgmental and consistent. Time should be provided to create memories, allowing the parents to dress, diaper, bathe, feed, hold in their arms, and take pictures of their baby. Skin care should be maintained. Medication for pain relief and discomfort may be used. The spiritual, religious, and cultural values should receive. Prayer should be allowed based on their religious background. And, you know, there is one group, they wanted to light candles, and let them light candles, but be sure it should be away from the oxygen, and have their clergy there, you know, whatever, if they want to baptize the baby, if they want to give azan to the baby's ears, that should be really respectfully offered. And this is consent to withhold. This is the DNR thing in our, each hospital has it. They come to the conclusion, and then the doctor has to sign it. 2 doctors should verify it, and so on. And these are some of the recommendations. And cardio, do not resuscitate. And this is a baby I took care of long time ago, and the baby was did not make it. He was one of the twins. No, one of the twins. And this is one of our nurses, Mary. She worked with me for so many years, and she is the respiratory therapist, Rosa. I don't know, do you have respiratory therapists in your teams now?
No, sir, currently.
You should start that. I think that's a good thing. Okay. Care of parents after baby's death. Showing kindness and compassion is a must. Walk the parents to their transport vehicle. When they're leaving, they should not have the feeling that they're leaving alone. You should walk with them. That is the highest height of kindness and compassion. This will prevent the feeling of leaving alone, and they should be given a memory box. This will avoid walking out with empty hands, just like during wars and deaths. When the family is leaving, especially to the mother or to the wife, the flag is given, and here she carries that, and that is the height of kindness to be shown. Should be, I'll show you the memory box. This will avoid walking out with empty hands. And this is the memory box. It can be developed also. Take a good box, and in that you put a little baby hat, a little ring, ribbon, and also record the weight, length, head circumference, and the gestation age, and give that to the family and let them carry in their arms so that they don't feel that they're walking empty-handed, and walk with them. So a summary, survival rate for very preterm infants has improved over the last 2 decades. And it is still improving. Infants born at threshold of viability present a variety of complications, medical, social, and ethical issues. Although the incidence of such birth is only 2%, the impact on these infants, their families, the healthcare providers, and society is profound. Parents, obstetricians, neonatologists, and nurses have to deal with these difficult scenarios, especially our younger residents, medical students. So we should get them involved. Many difficult medical and ethical decisions have to be made, which leave lifelong impressions on those involved. Sometimes we think, did we something wrong? Did we do appropriate? So those things will come, and this should be discussed and in post-death counseling. That. These are my references, if you want to use them. And to the parents, residents, medical students, nursing staff, respiratory therapists, pharmacologists, and my colleagues, and the medical librarian. So professionalism through reflection. A few years ago, we had the privilege to take care of a baby at the threshold of viability. After initial response to therapy, the immature organs started failing. Palliative care was offered and was accepted by the family. The small NICU room started filling with women and sturdy ranch hands. These were ranch hands, those who work on farms, and this was a baby from a small town, with tears in their eyes and their hats held to their chest, with their heads bowed in prayer, led by their pastor from their hometown. To them, he was their baby, the son of young parents. To us, he was a micropreemie. This was happening with me in the NICU in Amarillo, Texas. These are sad things, but we have to go through them. This is a poetry by a poet. So it says in Urdu, you will be understanding, khil ke gul kuch to bahare janfisha dikla gaye. That is, some flowers buds opened up and showed their color and fragrance. Hasrat un gunchon pe hai jo bin khile hi murjha gaye. These are the premature tiny babies who didn't do anything. I think, did you follow me with this poetry?
Yes, sir.
Okay, good.
It's brilliant.
And so I took this picture one time. One of my relatives' baby died at threshold. So I took this picture and sent it to the parents. So we mourn the withering away of the flower buds which faded before they could blossom. So it's the same thing, but it's an English description. Thank you for your time and attention, and I hope you got something out of it. So maybe just give me a few feedbacks, and you think how should we improve more? Anybody?
Thank you so much, sir.
Okay. And
thank you so much. It's very informative and very knowledgeable for us.
Okay.
And so we are
Thank you
working
so
in
much,
a
sir.
beg your pardon?
Sir, I want to share the scenario over here. It is, I think, not shared. You can listen me.
What's that? I couldn't understand. Ji?
आवाज आ रही है?
हाँ जी, अब आ रही है। डॉक्टर विक्रम बोल रहे हैं ना?
जी सर।
हाँ, अच्छा बोलिए।
जी, मैं ये कह रहा था, हमारे पास वैसे पाकिस्तान में जो है ना 28 वीक्स मोस्टली जो है लोग रिससिटेट नहीं करते या वायबिलिटी कंसीडर नहीं कर सकते। फ्यू सेंटर्स हैं जहाँ 24 वीक्स की एज ऑफ वायबिलिटी कंसीडर करते हैं और 24 वीक पे रिससिटेट करते हैं। शुरू जब अपना सेटअप स्टार्ट किया था यहाँ पे इंडस हॉस्पिटल में 4 साल पहले, तो हमने ये रखा था कि 24 वीक्स एंड अबव ट्रीट करेंगे। लेकिन अगर फर्ज करें 24 to 26 वीक्स पे जो बेबी हैं, उनको रिससिटेशन की एक्सटेंसिव नीड पड़ रही है, तो फिर उनको रिससिटेट नहीं करेंगे।
अच्छा, हाँ जी, हाँ जी, दिस इज जस्ट बोलिए।
करते हैं, वैसे 26 से ऊपर हम रिससिटेट कर रहे थे, क्योंकि वो सारी चीजें वो उस लेवल की हो जाए ना, तो ताकि उस पे बंदा वो कर सके ना, तो उस हिसाब तो थोड़ा बहुत ये सिनेरियो वैसे आपको बताना था। अभी हम 24 आवर्स रिससिटेट करते हैं, लेकिन इनके रिलेटेड आउटकम जो ना 24 वीक्स पे नॉट सो गुड, 26 वीक्स इज वेरी गुड, 24 मतलब इज नॉट अप टू द स्टैंडर्ड एज इट शुड बी।
हाँ जी, ये ठीक बात है। 25 वीक्स बिग लैंडमार्क, यू नो, मैंने शुरू से देखा था कि जब मैं यूनाइटेड स्टेट्स आया था अबाउट 50 years ago, 28 वीक्स के नीचे कुछ नहीं करते थे।
Vamos a entrar en YouTube ya. Vale. Ya estamos en YouTube. Juan Manuel, ¿vale? ¿Estás preparado? Y entonces, en el momento que empieces a hablar tú, sale tu cara. O sea que, ¿vale? Entonces le voy a dar ya a iniciar seminario web. Entonces abrimos Zoom porque son las 9 según mi reloj. Entonces ya se están incorporando las personas.
Buenos días.
Hola Javier. Nos estaba diciendo, le he dicho antes, que mientras hablan los que van a hablar los primeros, en principio los demás apagáis vídeo y audio, ¿vale?
Ujú.
Hola Javier. Esperamos si te parece un par de minutos, Juanma.
Sí, perfecto.
Pues ya